Good afternoon. Odessa Regional Medical Center and Scenic Mountain Medical Center employees and medical staff. I'm Stacy Brown, president of both facilities. I'm excited to be your moderator again today as our Chief Medical Officer, Dr. Rohith Saravanan, talks to us all about COVID-19. Remember that you can submit questions in the chat box, and then we will ask him your questions live, and then he can respond to you. So that's what will make this most interesting, I think, is if we do have a lot of interaction. I do hope all of you recognize how fortunate we are to have Dr. Saravanan in this role for both hospitals. I can tell you from my point of view, I cannot even fathom having gone through this pandemic without him by our side to lead us. He is not only our expert in COVID-19, but he has been called upon in both of our communities and beyond, quite frankly, to give his opinion and his thoughts on different things as it relates to the pandemic. So he's incredibly knowledgeable and excited to share that with you today. So again, please submit any questions that you may have. With that, I'll turn it over to you, Dr. Saravanan.
This is now our third town hall for both hospitals, so RMC and Scenic Mountain, and we're happy to host these so that we can get some questions out there. We're happy to answer a lot of the difficult topics that our employees and their families have questions about. So we can probably get started with some of the questions. I have always opened with saying that in our community right now, we're doing still okay with regard to COVID-19. The positivity rate in our community is starting to come down, which is a very good thing. Previously we were as high as 40 to 45% positivity rate, but now we're probably down closer to about 20%, which is half the positivity rate of before. So that's a very positive sign. And the hospitalization rate, which is the second metric that we follow, is the number of operational beds in our hospital that's taken up by COVID-19 patients. Remember, COVID-19 is one condition that's taking up a certain percent of the hospital beds. At a certain point in time, we were at well over 25% of the operational beds taken up by this one disease process. Now we're probably down to about 10% of our hospital beds taken up by this process. That still is 10% of an entire hospital taking care of one disease condition, even though there's 1,000 others that we serve. So right now at Odessa Regional, we have about 20 patients in our COVID census. 16 of those are in the ICU, several of them on ventilators, and only a few of those are on the regular floors. As you can see, that split's not normal for any disease condition. Most people are on regular med-surg, and a few people will be in the ICU. This is the opposite for the COVID patients that we have. It shows you that the people that do get hospitalized are usually very sick and require pretty intensive care. At Scenic Mountain, our COVID census has continued to come down. At a certain point in time, you might remember, more than half of the entire hospital census at Scenic Mountain was COVID-19 patients. Luckily, it has started to come down, and we're now down to a handful, if not less. Actually, today was just 2 COVID-related cases in the hospital at Scenic Mountain. So that's also another positive sign. Neither one of these 2 positive signs means that this disease process is over in our community. It doesn't mean the pandemic has passed. It still means this is a very real threat. It really does affect our community, and there are still several people that are very vulnerable to getting very sick. Remember, the ones we see in the hospital are only those who've gotten very, very sick. The vast majority of people with the disease are still out and about or at home recovering without needing hospitalization. So this is still very much in our community, and we need to be careful and still maintain all our preventative measures that we've done so far. So with that kind of opening, I will start to take some questions.
All right, so I'm going to open it up to Stacy. She's going to be moderating us today. We already have a couple of questions that have come through. So Stacy, I will send it over to you.
Thank you very much, Madison. Good afternoon, everyone. So Dr. Saravanan, can you please talk about mask post-vaccination?
Yeah, so masks post-vaccination is a very good question and a very important question because there's a difference in understanding of what a vaccination does versus what a mask does. So let's start with mask first. Mask is a physical barrier that goes over your nose and your mouth. It prevents droplets from coming out of your nose and your mouth, and therefore those droplets that carry the viral particles will be blocked for the most part and will not spread to another person. So the utility of a mask is primarily to stop the spread of disease from you to someone else. Of course, it provides some protection for you as well because it provides the same level of coverage inside out as it does outside in. So it'll prevent those droplets from being breathed in by you. So masks is providing that level of protection. Now let's talk about vaccines. Vaccines are giving you immunity to a viral particle. So you are forming antibodies in your bloodstream that will prevent you from getting sick from a virus. So the virus will still enter your system, will still go in to your bloodstream, but immediately be killed by the antibodies that you have formed because you are fully vaccinated. So a vaccine provides you personal protection. Means you won't get sick from the disease. It doesn't mean you won't be exposed to the virus. It just means you won't get sick from it. So the difference between a vaccine and a mask is that the mask is a physical barrier. A vaccine is protection with antibodies that you don't get sick from. So even after getting the vaccine, you can still get exposed to the virus. It can still live in your nasal mucosa, in your mouth, and you can still spread that virus to someone else. So the use of the masks after vaccination, the utility of the mask still continues because you will still protect yourself from getting exposed and you'll still protect others from getting exposed.
Okay, thank you. What about if I get COVID after being immunized? Do I have to quarantine still, and for how long?
The question was if you got COVID. So remember the vaccines are 95% effective after the second dose. About a week after the second dose, you're considered 95% chance that you probably won't get COVID. But if you do get COVID, that you're diagnosed with COVID, that means you're part of that small 5% that ended up getting COVID even after the vaccination. So yes, you have COVID, therefore you need to quarantine, and those same principles will apply, but it'll be the vast minority of people that'll fall into that category. Let me take that question a little bit farther. What if you get exposed to COVID after you've gotten the vaccination? Let's assume the 95% effectiveness is protecting you personally. What if you get exposed to someone that has COVID? The answer to that is, well, twofold. One is, yes, you are personally protected from COVID, therefore you won't get sick. But if you weren't wearing a mask around someone that had COVID, it is very possible that you got exposed to it. That means it's in your nasal mucosa and it's in your mouth and you can still spread it to other people. So yeah, if you weren't wearing the appropriate personal protection when you got exposed, or if you aren't able to isolate from someone at home who is sick with COVID, yes, you do need to quarantine. But if you are able to protect yourself, you're continuing to isolate from a person that's sick, then you do no longer need to quarantine because you yourself will not have been exposed and will not be infected with the disease.
Okay. Our next question is, when should people report vaccination side effects?
They should report it immediately after it occurs. So just because we know that vaccinations have side effects doesn't mean you don't tell your employee health that you're having them. We want to know so we can report back so that the data can be used to further understand what the side effects are going to be, what percent of the people are going to have those side effects, etc. So even though I will tell you now that you can expect that you may have arm soreness, you may have some fatigue, you may even have fever and chills after the vaccine, especially after the second dose, which is what we expect a little bit more reaction to. It doesn't mean you don't report it to employee health, because that's still reported back through the vaccine adverse reaction system to the state and to CDC, and then they use that to publish more data about what to anticipate in the future for others that are receiving the vaccine.
Okay. Should people call in sick if they think the symptoms they are having are due to the vaccination?
Well, it's safe to assume that if you're having symptoms that are new the day after the vaccination, it's safe to assume that it is likely from the vaccination. Should you call in sick? Well, you are not sick in the sense that you're infected with something that you could spread to other people. So if you're asking, should you call in sick because you can protect other people, the answer is no. You're not infected with something, you're just reacting to something. So if you physically feel up to it, if you feel like you can still accomplish what you need to at your job, then yes, you need to show up and do your job. If you feel like you can't, then yes, you need to call in sick.
Okay. Can a person who has mild COVID-like symptoms come to work if they've been vaccinated, or should they stay home like we've been doing up to this point?
So if you have COVID-like symptoms, that list is quite long, we've gone through it many times. If you have COVID-like symptoms, means you are sick with something. Now, this is unrelated to whether or not you received the vaccine. You are sick with something. So you have cough, cold, flu, COVID, some sort of viral common cold, any of the above, or you could have something else. The fact is you're sick. So if you are sick, no, you should not come to work. You should go see your primary care doctor. You should call employee health. You should call your director and talk to whoever your supervisor is and talk to them about what to do next.
Okay. Can you talk about the new strains of COVID-19?
Sure. So there's at least 3 new strains that we know of and have identified so far, and we believe all of these strains are already in the US. We know about the strain that we discovered in the UK. We know about the strain we discovered in South Africa and the strain we discovered in Brazil. We don't want to label them as location strains because we're not trying to create, a certain location as the fault of a strain. I mean, it's just where it was discovered. It could have come from anywhere. But those 3 different strains we know of, we think that all those strains are making the virus more virulent. It's a property of a virus that makes it more infectious, faster replicating, giving you more symptoms, etc. So those 3 strains are showing a little bit more virulence than the previous strain that we knew about. But as far as we know right now, the vaccines that we have are working against all 3 strains. The treatments that we have are working against all 3 strains. The only property of these new strains that we know of is that they are replicating faster and therefore making people more infectious in a short period of time. So that's the only difference that we have so far. The tests that we do, like the PCR test or the antigen test, all of them will catch COVID. No matter what strain you have, you'll still be able to discover that you're positive or negative, no matter what the strain is, and the vaccines we're giving should protect you against all strains. There is some studies coming out right now that are saying that the vaccines are a little bit less effective in certain strains, but that's not fully proven yet, and that data has not been published and accepted by the scientific community. We will know more as these strains develop, and we'll know more as we get more people vaccinated.
This question's still very similar, but I want to go ahead and ask it so that it's asked in the way that the person who posted it intended. But how concerned do we need to be about these new variants or mutations of the virus?
The truth is, we don't know how concerned we need to be. So because we don't know, we are very concerned. And one of the things we do when we get concerned is do a little bit more research on these new strains. We start testing these new strains against the treatments we have. We start testing these new strains against the vaccinations we have. What we do know so far is that when these new strains come to a population, that population that gets infected, it is spreading a lot faster with these new strains. It is spreading faster because it is replicating faster within each person. So yes, we are concerned about the new strains. The virus, this is how science works. A virus tries to survive, therefore it has to mutate in order to survive. That is the property of a virus. And we as human beings have to figure out how to make sure that we understand these mutations and appropriately develop countermeasures to these mutations. So as of right now, the vaccines we have seem to be working against all the strains. But if one of the mutations changes the spike protein against which our vaccines are created, then it is possible that we may need to change our vaccination. We might need to give a different booster that'll allow us to recognize the new strains of the virus.
Okay, can you speak a little bit about the testing that's now available for COVID, such as the saliva versus the swab?
Sure. So testing that is available for COVID right now, there is the tests for diagnosis and there's the tests for exposure. The test for exposure is the antibody test. An antibody test at present is a qualitative test, not a quantitative test. It doesn't measure the amount of antibody. It just measures whether you have it or not. The result from that test is basically showing you, have you been exposed to COVID before or have you not been exposed to COVID before? So that's one set of testing. The diagnostic tests, there's two. There is the PCR, which is a nucleic acid amplification polymerase chain reaction, using polymerase chain reaction. That test, the PCR, is the gold standard because it is the best test we have. I'm not saying it is the perfect test, but it is the best we have. So that's what we use for diagnosis of COVID. Once you do a PCR, if it comes back positive, you have COVID. If it comes back negative, you don't have COVID. The antigen test is the other test, and that test is not doing any nucleic acid amplification. It is simply testing if the specimen that was collected without amplifying, whether it can identify COVID or not. So if you think about the antigen test, if it identifies positive for COVID, then yes, there's COVID, there's that coronavirus in that specimen. But if it's negative without the amplification, there is a small possibility, 20%, that it could miss a positive test. So an antigen test is 100% accurate for positives, but only about 80% accurate for negative. It misses 1 in 5 positive people. So therefore, some of those people who get an antigen test who test negative may require a confirmatory PCR, which is the gold standard. Now, with regard to specimens, you can run these tests on many different kinds of specimens. The specimen is either a nasal swab, a nasopharyngeal swab, which goes deeper into the nose, or saliva as the specimen. You can run these tests on any specimen. So what we've found so far is that saliva is a fair specimen to run this test on, and therefore you'll find like our city-free testing at Floyd Gwynn Park in Odessa, that one uses the saliva collection, but the test that is run on the saliva is still the PCR. So as long as you're running a PCR, it doesn't matter if it's a nasal swab, nasopharyngeal swab, or saliva, and that's the differences between the tests and the specimens.
Okay, I think this next question is a really good question. If you have been vaccinated, will you show as positive on the antibody testing?
Yes, most likely you will show positive on the antibody test because an antibody test is either looking for you having been exposed before and creating antibodies or you being vaccinated and creating antibodies. So you will likely show positive on the antibody test. Again, not all antibody tests are made exactly the same. And in this specific case, There's certain antibody tests that is testing for an antibody against the ACE receptor for which the virus uses to get in the system. Those will turn positive. But if it's a different kind of antibody test, then it might not. So that's not a good measure to say, hey, did I develop antibodies after the virus? Am I immune now? That is, the antibody test is not a good measure for that at this time. We will get to a point where we'll measure titers. That's the quantitative analysis. It'll actually measure the amount of antibody you have. And if you have a certain amount of antibody, a certain titer, then you can say, yes, I'm immune at this point, and I'm not immune if my titer is lower than that. But that is not out there yet for us to use. So for now, I would not depend on the antibody test to see, am I immune or not?
Okay. Has the length of immunity from the vaccines changed? Or will we expect another series of vaccines?
Yeah, so this is also a complex question. So the length of immunity from a vaccine depends on many different things. Let me talk about just two of them for now. One is that when you create antibodies, then you're assuming those antibodies stick around for a certain period of time. Now, with a vaccine for which you give a booster, we expect those antibodies to last for years and decades. For example, we all got our MMR shot when we were kids. And so we expect that those antibodies for measles, mumps, and rubella that we got when we were kids with multiple boosters will last for our lifetime. So the antibodies response is going to be there in our body for our whole life. So that brings us to the number 2 point. If the virus mutates and that antibody no longer can recognize that virus, well, it doesn't matter if you have those antibodies or not, you will need a booster regardless. We don't know how much this virus is going to mutate and if it's going to mutate the spike protein against which we've created the antibody. So as of right now, it's fair to assume that once you get your 2 shots, your first shot and your booster, you're good. You don't need any more shots after that. But we will keep an eye on the virus, and if it does mutate, you might need more boosters. There are some viruses that mutate a whole lot, like the influenza virus. That's why we immunize against it every year. And there are some viruses that don't mutate a whole lot, like our measles virus that we haven't immunized against since childhood. The coronavirus seemingly falls between these 2 viruses. We know that it does mutate, but it doesn't mutate nearly as much as influenza. So it is a matter of time before we can actually learn enough about the mutations to see whether we'll need more boosters for these vaccines or not. Okay.
Would you speak to the vaccine availability at both of our hospitals?
Sure. So so far at Odessa Regional, since the first week, since the last week of December, so around Christmas is when we started to receive vaccines, and we received vaccines for several weeks, and we had a total of 2,000 vaccines given to us in Odessa Regional. At Scenic Mountain, we had a total of 400 vaccines given to us. Now we're waiting for the second doses for those 2,000 at Odessa and the 400 at Scenic Mountain, and so far we've been getting most of those second doses, except for this week at Odessa Regional. We did not get 100 of those second doses. Hopefully they will make up for it and it'll continue. There is no first doses that have been sent to either hospital in the last 2 to 3 weeks. So we haven't had any more first doses sent to us, which means we depend now on the vaccination hubs that have been created in our area. There's 5,000 a week coming to Midland Memorial and 4,000 a week coming to Medical Center in Odessa. And between those 2 big hubs, we can cover our whole population area, even the surrounding areas. And that's what we've been trying to do. No new first doses have come into either of the 2 hospitals, so nothing new is available. But if you've gotten your first dose at one of those places, you will get your second dose. You may be a little bit delayed, but you will get your second dose.
Okay, Dr. Saravanan, what about the vaccine availability in our broader community?
Yep, so just those two hubs that I talked about, Midland Memorial and Medical Center Hospital. Midland Memorial Medical Center Hospital have chosen to take on the West Texas surrounding communities, and they have split up the different counties, and each of them has taken on a leadership role in reallocating or bringing in those communities into their hubs to give out the vaccination. So for example, Scenic Mountain received a reallocation of almost 750 shots. That was 2 weeks ago from Midland Memorial, and we're hoping that they will send us even more this week so we can continue to vaccinate the Big Spring community. So those are the kind of things that the hospitals are doing in addition to their vaccine hub model. Medical Center has a model which is at Ratliff Stadium, that's a drive-through, and Midland Memorial has one that they do by appointment. So each of them has their unique styles, but the goal is to vaccinate as many people as they can that fit into those categories. Right now, Texas's approach has been those vaccination hubs. Because they want to get the vaccine out to as many people as possible. Therefore, they're not giving vaccines out to any of the pharmacies, any of the other providers. They're giving the vaccines primarily to those vaccine hubs. They will shift their criteria once they feel like they have covered a lot of those vaccine hubs and the demand starts to come down. They will start to give out the vaccines to the smaller providers as well.
So you do believe then that the Midland Memorial second doses for those that were donated, that we will get those for our community in Big Spring?
Yes, there's no reason to believe we won't. So we'll have to wait to see once those get shipped.
Okay. What about being able to vaccinate the families of our frontline workers?
Yeah, that's always been a difficult question as well. And, you know, everybody is important in the community, but the way that we have approached the vaccination process is that we need to protect those first that take care of others. And that's our frontline workers. And second, we need to protect those that have high risk of complication from this disease process, those that will get hospitalized, those that could potentially die from this disease. So that has been the phases that Texas has followed. So Texas phase 1A was frontline workers, and Texas phase 1B was people over the age of 65 or people with chronic medical conditions that makes them high risk from this disease. So those are the phases we've been following so far, and I'm hoping that once we catch up with a lot of those people, we will start to open up to even more of the community. So it is, yes, we want to vaccinate teachers, and we want to vaccinate essential workers in other industries. So all of those people will be included. It's just a matter of time. So, and the matter of time, I'm hoping, is not more than a few weeks.
Okay.
The fact that we waited for 10 months since this pandemic started locally for us, I don't think a few weeks is going to make a big difference in our community. So as long as we stick to the precautions and as long as we keep our social distancing and our masking on, we will be okay for a few weeks as we wait to for the vaccine distribution to catch up.
Okay. Can you talk about the long-term side effects of the vaccine?
So we don't know of a whole lot of long-term side effects from the vaccine, but I can tell you that through the emergency use authorization process that the FDA goes through, it is required for them to monitor patients that have received the vaccine for at least 60 days and submit that data. So about half of the people in the studies, and remember these studies were tens of thousands of people, 45,000 people that got vaccinated, at least half of the people that were vaccinated with both doses have to cross about 60 days and show that there is no serious adverse effects before the FDA even considers emergency use authorization. So that process has been followed. It is very likely that vaccine side effect, if it's going to happen, is going to show up within the first 30 days of receiving that vaccine. So the fact that the FDA has that 60-day rule to make sure that it was safe before it issues an emergency use authorization, I think provides us as scientific experts, provides us enough assurance that the vaccine is safe. As to much longer term side effects, we don't know yet. And to the best of our knowledge, we can guess what's going to happen based on what the vaccine is made of, and none of the components of the vaccine make us think that there would be anything unsafe to the public. Otherwise, we wouldn't take them ourselves. So yes, it's considered very safe, and that's why it's out there.
Okay, can you speak to the new vaccines that are going through the process of approval?
Sure. There's about 38 different candidate vaccines that are going through the process. The process is all the way from a phase 1 trial to a phase 3 trial, and then submission to the FDA for emergency use authorization. Different vaccines are at different parts of that, different stage in that process. We now have Johnson & Johnson that has submitted its emergency use authorization application to the FDA, and it is being processed. So we are hoping and looking forward to having another vaccine that will soon enter circulation with emergency use authorization with Johnson & Johnson. The other one is the AstraZeneca vaccine, and that one has not submitted yet, but they think they're going to be submitting sometime in March for emergency use authorization. There is, however, a difference in the different vaccines. So I'll talk just about the Johnson & Johnson for now. The Johnson & Johnson vaccine uses a viral vector. A vector is basically a carrier. So it uses what we call an adenovirus, one of the viruses that cause the common cold. It uses an inactivated adenovirus as the vector to carry the mRNA that is required to process a protein, a spike protein, inside a cell. So we have the Moderna vaccine and the Pfizer vaccine that is specifically an mRNA that is injected directly into the cells that then creates the spike protein and then causes us to have immune response antibodies. And now we have Johnson & Johnson that's using another virus, an adenovirus, with the COVID-19 specific spike protein mRNA that's now injected that can enter cells and then cause that as well. The difference between the two is that one is very directly injecting the mRNA into the cells, and we are seeing 95% effectiveness in preventing disease after the 2 doses, versus the Johnson & Johnson is using this viral vector model, and we're seeing about 65% efficacy in that Johnson & Johnson vaccine. Now that's an overall efficacy for all levels of disease. If you look just at severe disease, it's protecting 85% of the people from severe disease. And that's really what the point of a vaccine is. Also, the Johnson & Johnson vaccine doesn't have any of the cold storage requirements that both the Moderna and the Pfizer vaccines have. And the biggest up is that it's a single dose. So with a single dose, you're able to get reasonably good effectiveness. Now, if we look at 95 and you compare it to 65, it doesn't look so good. But 95 is a very special number. That's actually not normal for most vaccines. The 65 is more normal for most vaccines. So the Johnson & Johnson vaccine is going to be a lifesaver for especially several parts of the world that cannot do good cold storage, and that also for populations that compliance is very hard to achieve for the second dose. So the single dose and the lack of cold storage will make Johnson & Johnson one of the top players around the world.
Very good. So there's obviously concern with the recent delays we've seen on the second doses. So one listener wants to know if it'll affect the outcome if you're late on getting that second vaccine, and how long can you go without losing the effectiveness?
Yes, excellent question. So in studies that they did before they published for the emergency use authorization through the FDA, those studies specifically followed these vaccines in a window of a 4-day grace period. For Pfizer, that grace period was 17 to 21 days, and for Moderna, it's 24 to 28 days. So that's when we knew for certain it would be 95+% effective. But now that the vaccine has been given out to millions and millions of people and more time has passed, we've learned more about how it is effective. So the CDC has actually increased the window all the way up to 42 days, 6 weeks. So from the first dose to the second dose, they have opened up the window to up to 6 weeks after the first dose for it to be still very effective. Now, they're not saying delay your second dose for 6 weeks. They're still saying get it within that 4-day window if you can. But if you are delayed, that's okay. You'll still be okay for up to 42 days after. Nothing magical happens at 42 days either. So if you're delayed by, let's say, 3 months, it doesn't mean the vaccine won't be effective. It just won't be as effective as it would have been if it's gotten within the time frame that's recommended. So we should all try to stick to the guidelines within those 4 days. If we can, second option within the 42, and the third option, worst option, wait for it even longer, but definitely get the second dose. Doesn't matter how late it is.
Okay, thank you. We do have one listener who would like for you to speak again to what herd immunity means. Sure.
Herd immunity means different things for different vaccines and different disease processes. So the honest answer is we don't know at what percent immunization in a population do you achieve herd immunity. We don't have the answer to that question exactly. What we do know from many different viruses is, between that 70 to 80% of the population, when it's immunized, that's when you start to recognize what's called herd immunity, because you're more likely to be around someone that's immunized and that is immune to the disease than you are to be around someone that's not immune. So at this point, it is unlikely for the virus to spread really quickly and for it to become a pandemic. And that's the reason we use the word herd immunity. So there's a few people within us as a herd, human being herd, that cannot get the vaccination. How are they being protected if they cannot get the vaccination? Maybe because they have some sort of a contraindication to the vaccination. Well, they depend on herd immunity. So if the majority of people are vaccinated, then they are protected as well because the majority of people are vaccinated. We don't have an exact number for that, but the best estimate is about 70 to 80%.
Okay, we have a couple of questions coming up next that have to do with how we can proceed in our daily lives with various things and still stay safe. The first one is going out to a restaurant.
Yeah, I mean, I miss it just as much as everybody else, and going out to eat is a very going out to eat is a very social thing. It's one of those things that we enjoy, but there is risks and benefits to doing each thing. So that's what we need to recognize as we evaluate each of the things we're going to do. Like going out to a restaurant, we have to evaluate, okay, how is COVID in our community right now? Are the rates high or the rates low? What is my risk of getting exposed? Is the restaurant following the masking guidelines? Is the restaurant following the guidelines of spacing out the table to 6 feet apart? Are the servers wearing masks and are they being careful while preparing the food? All those is what really makes us evaluate how restaurants can keep us safe. So each thing requires a little bit of an evaluation. There are several questions to ask before we decide does going to that restaurant that day make sense or not.
Okay. And then how would that vary for something like getting a haircut, for example?
Yeah, so, I used to get a haircut every 3 weeks, and now I get a haircut probably every 6 to 7 weeks. And so it's all about the risk, right? So you're going to a haircut place, you start to look around and you say, are they socially distancing? Is the hairdresser wearing a mask? Are you wearing a mask during your appointment? If all of the above are true, then you have reduced your risk. Doesn't mean your risk doesn't exist. So you've reduced your risk. You've reduced the frequency of your haircuts. You're making sure there's distancing, and you're making sure that everyone that's interacting with you and you are wearing a mask at all times. And that's how you can reduce your risk for haircuts.
And so the next one has to do with travel, and we're going to use an airplane as an example. When this first started and travel started opening back up, we were hearing that the airplanes were really spacing out the passengers as well as mandating a mask. But now we're hearing more and more that they're only mandating the mask, that the planes are much fuller. So what kind of risk does that pose?
Yes, so again, it's about evaluating the risk. There is HEPA filters on airplanes. So when the air is recirculated, there is good HEPA filtration systems that will capture the viral particles and not recirculate it within an airplane. But if you are sitting next to someone within 6 feet and they're coughing and you walk through their cloud of cough or sneeze, then yes, you can still inhale it. So even on an airplane, social distancing and masking become very important. In addition, what airlines have done, is they're requiring a negative test before you travel, not for domestic travel, but especially for international travel. So perhaps making sure that you isolate before you travel, making sure that you test before you travel, decreases your chance of giving the virus to someone else. And you're hoping that your community will do something very similar as they choose to travel as well. There are less peak times for you to travel to reduce your risk. There are also certain airlines that do better at screening people before they let them on, like taking their temperature, asking the right questions. So choose those kind of airlines. Keep your flights as short as you can. Keep your exposure within the airport as short as you can. And those are the things you can do to protect yourself during travel. Same goes for somebody that's traveling by car. If you're in your own vehicle and you're driving somewhere, your risk of exposure is 0. Because that's your vehicle, but your vehicle stops places like gas stations, like places where you pick up food, or places you might go to where you might need groceries. So plan accordingly and plan early. Fill up your gas tank early. Try not to stop at a place to sit down and eat. Pick up and keep going. Keep your mask on during your pickup. If you're going to need groceries where you're going, get the groceries from here so you're already safe and you know what the exposure risk is before you go out somewhere else and get groceries there. Those are the kind of things that you want to be able to do.
Okay, and this may seem a little bit redundant, but it's still an important one, I think. So this one has to do with bars. And so we know bars are much more social and all of that, but is there a way to mingle in a bar and still be safe or lessen the risk significantly?
Bars is a tough topic. So if you think about what a bar is meant to do, it is meant to bring people together. It is meant to get people to congregate. It's meant to be loud. It's meant for you to get up close to someone else and talk. So it's hard to justify the bar atmosphere when it comes to infectious disease. That's one of the worst places you can be. And so a bar is probably not the kind of place you want to be at. Now, there's different social ways of sharing a good drink with a friend. There's good social ways of doing it virtually versus keeping the group small in a home setting where you can still socially distance and be careful with your risk level. Those are the ways to be able to do that. I don't think bars are a good place to be right now. As we start to improve, as we start to get better, then we can open up more and more. Stacey, I can't hear you.
I'm so sorry. Thank you for explaining all of that. I know there's a lot of kind of similar examples, but yet still different. So this next one is a question of hope. When do you think that we can hope to throw away our mask?
Yeah, and that is the question on all of our minds. And I really wish the crystal ball could give us an answer. But you know what I'm going to say on this. And the truth is we don't have a crystal ball, but we do have good scientific data. And day by day, the scientific data is improving. So our predictions keep improving on how things are going to go. This is also going to be very much of a regional question. It is not going to be the same answer for the entire nation or the entire world. Specifically for us here in West Texas, it's going to be a little bit different. So the best way to answer this question is if we can continue getting people vaccinated if people's demand for the vaccine still continues to remain high, if we still continue to do our social distancing and our masking and we don't let this disease spike again, if all of those conditions are met, my prediction is that probably within about 6 months, we can start to get to a point where we can say there are places we can be or we can be with more and more without our mask on, more and more without social distancing. What we have learned through this pandemic is that social distancing and masking works. One of the telltale signs is that you don't see flu this year. There is no flu this season. And the reason we don't see the flu is because everybody is socially distanced or masked. So we know that this is going to be a part of our future, no matter if there's COVID around or if there's not COVID around. We have learned how to prevent the spread of infectious disease. So masks and social distancing will always be a thing in our lifetimes, but it will become more and more normal as time passes by, and there will be more and more places we can safely do without masking and social distancing as time passes by. My prediction is about 6 months, so late summer.
Wonderful. Our next listener wants to know, do we have ultra cold storage to store the Pfizer vaccines at our hospitals?
Yes, at Odessa Regional, we do have a deep freezer in the OR setting, and so we do have space, ultra cold storage available there. The truth is, we don't really care whether we have ultra cold storage or not, because the vaccines are not lasting that long. The Pfizer vaccine is good in the fridge for 5 days. Pfizer vaccine is not going to be around for 5 days. If it gets to us, it'll be gone within the first couple of days. So we're not even going to put it in the ultra cold storage. We're going to put it in the fridge. We're going to start to reconstitute and give it out, and it's good for 5 days in the fridge. The Moderna vaccine has even better shelf life in the fridge. It's good for 30 days in the fridge. So we would never put it in the freezer. We would put all of it in the fridge, and as soon as we get it, we'll open it up and we're out within the first couple of days. So the ultra cold storage for us right now has not been a problem. It is at the federal and the state level as they are holding certain stock to be able to send out for second doses. So they need the ultra cold storage facility in their storage and distribution facility. But we, as a provider of the vaccine, probably won't ever require it because it'll be gone within a few days of it being here.
Okay. So there's people who believe that they do not need to get the vaccine because they've already had COVID. So how long do they carry the antibodies? How many times can you get COVID, and could it get worse each time?
Yeah, and each of those questions is a very good question. Unfortunately, we don't have a clear answer on many of those questions. What we do know is that people who do get COVID, the disease, will develop some sort of antibodies. And you've seen before that we have estimated that to be about 90 days. So 3 months after you recover from COVID, we say that you're probably still immune to COVID. So we don't test you again unless you develop symptoms for COVID again. So can you get COVID a second time? Absolutely. How long do we think the antibodies last? Maybe 3 months. Is getting COVID a substitute for getting a vaccination? No, because the antibodies that you get from active disease process is not the same as first dose and booster. The first dose and booster make sure your antibodies last for an extended period of time. And I'm using that vaguely because we don't know what that extended period of time is, but it's definitely more than 90 days. But once you get COVID, we assume that you only have those antibodies for 90 days, and we don't know for sure if those antibodies necessarily protect you. So even if you have had COVID, you do need to get the vaccine. You need to wait till you're fully recovered from COVID to get the vaccine. So a fully recovered is usually about 14 days from when you first started developing symptoms. Maybe 20 days if you got severely ill from those symptoms of COVID. So we wait 14 days. Once you're labeled as recovered, then go ahead and go get the vaccine.
Okay, so we've also been hearing examples of people who've had COVID with lingering after effects. What is the plan for aftercare?
That's been a very tough question nationwide. There are several big cities that have already started developing post-COVID clinics, clinics for people with post-COVID syndrome, and that's a loosely used phrase for anything that's an after effect of COVID. We don't know exactly what happens a year after you've had COVID, because we don't have data on people that are a year out from getting COVID. We will very soon, and we'll start to learn a lot more. But as of right now, there are a few providers in our community. For example, I'll call out Dr. Dar, who's our intensive care provider at Odessa Regional, who has been caring for COVID patients since the beginning of this pandemic and continues to care for them now, has been almost like a Lone Ranger intensive care provider for our hospital. He runs a clinic, and in his clinic, he does see certain patients that have post-COVID related symptoms, but there's still a lot of lacking data right now nationwide. So he's submitting some of that up to the national data banks, and he is getting back some advice from the national data banks. And as we learn more, we'll know how to treat these conditions, how long these conditions will last, how debilitating they can be. We don't have good answers for any of those right now.
Okay, thank you. And this is our last question. Is there any one place to go in our community to get the latest on COVID in our area and where the vaccination sites may be located?
Yes. So to directly answer your question, I think there's a joint effort between the city and several stakeholders within the community to develop a website, and a smartphone application. It is called COVID in the Basin. So the website address is covidinthebasin.com, and the app COVID in the Basin is available on Android platform as well as the Apple platform for you to download. That one resource will have all the resources you need from a local standpoint. So it'll have where to go for vaccines, where to go for testing, who are the providers that take care of COVID, where are the free tests available, how many vaccines are left, what is the current census of COVID, how many cases are there. All that information will be on that website. It'll link to the websites that we should be getting our information from. For example, the CDC and the FDA and the NIH. The CDC specifically will have great FAQs, frequently asked questions, about COVID, about the vaccine, about the disease process. It'll also have some information, latest information on things like masks. The FDA will have more information on the things that it approves, like the vaccines and the tests, and the NIH will have information about treatment guidelines. So those are the resources we use as physicians when we come up with plans to treat patients. So that's the resources we will link to on this website and this app. This app will be marketed pretty heavily, probably starting next week. It is just finished development right now, so I'm really looking forward to sharing that information with our wider community as well.
Okay, Dr. Saravanan, I believe that brings us to the end of our questions, so I'll hand it back over to you for closing comments, but I know we all really appreciate you taking the time to do this. I'm getting comments on here about how easy you make this to understand for everyone, and so just know you're greatly appreciated.
Thank you very much, Stacy. It's always a pleasure, a privilege to be able to share scientific data and to know that people are listening, because there's so many different sources of information, and some of those sources of information, unfortunately, are just opinions. And in the scientific community, us being in healthcare, we need to share more than just opinions. We need to share real data. We need to back up our opinions with data and be able to show our sources and say, this is where we get the information, this is how we justify it, and this is what we need to be spreading. Otherwise, there's always a chance for misinformation, and unfortunately, people suffer because of misinformation. So I do appreciate that we hold these. I appreciate the opportunity to share all of this good information, and I look forward to doing it again in the next couple of weeks.